Hey, I'm Biru Paul, a clinical researcher at the Libin Cardiovascular Institute, and I'll be presenting on the research I'm engaged in looking into NPR1 antagonism as a novel treatment for hypovolemic POTS. To begin, I want you to imagine that feeling after you've just finished a sprint. Your heart is pounding, you're gasping for air, and the world begins to spin. Now imagine feeling that every single time you stand up. For many people with postural orthostatic tachycardia syndrome, or POTS, that's their reality, because every time they stand, their world begins to run. Characterized by an increase in heart rate of 30 beats per minute or more in adults and 40 beats per minute or more in children within the first 10 minutes of upright posture, POTS affects an estimated 16 million people worldwide, and out of this, up to 90% of patients are women. And the hardest part of living with POTS is the fact that there are no approved treatments or medications. Care is often a patchwork for our patients, drinking more water, adding more salt to their diet, wearing compression garments, and trying off label medications. It's helpful for some, yes, but for many, it feels like trying to rebuild a house with nothing but duct tape. Here's where the story shifts. When you pay close attention to the physiology, a pattern emerges. Low effective blood volume, or hypovolemia, shows up in a large share of POTS. In fact, across studies, up to about 70% of patients have objectively reduced blood volume. That matters, because when the tank runs low, the heart gets less blood flow on standing and stroke volume lowers, causing the heart to sprint in order to compensate and maintain cardiac output. This ultimately causes the symptoms patients experience upon standing, such as lightheadedness, shortness of breath, and palpitations. So why can't we just fill the tank, get their volume to stay up? Meet NPR1, or natriuretic peptide receptor A. When this pathway is active, the kidneys let go of salt and water. It's the body's built-in drain. NPR1 is the primary receptor for hormones ANP and BNP, which stimulates the production of cGMP in the body. This causes physiological changes like vasodilation, natriuresis, diuresis, and reduces blood volume and blood pressure. In a person already prone to low blood volume, the strain being a little too open can keep the body's tank chronically low. This takes us to the idea we're testing. What if we gently cap the strain? Our team is studying a single dose monoclonal antibody designed to antagonize NPR1. We are working on an international clinical drug study testing two subcutaneous dose levels of our study drug in a randomized, double blinded, and placebo controlled test, asking a simple mechanism matched question. If we close the NPR1 drain just a notch, do we see steadier standing heart rates and objectively higher blood volume in our patients? This drug, Region 7544, is the first to be developed for and tested to target a core mechanism in POTS. Participants aged 18 to 55 are randomized into three cohorts, two drug levels, and a blinded placebo. Hemodynamic assessments, including stand and supine blood pressure and heart rate, are collected over 8 study visits. Serial blood samples will be collected for pharmacokinetic and pharmacodynamic profiling and the detection of anti-drug antibodies. Our study aims to assess the pharmacodynamic effects of a single dose of Region 7544 on orthostatic heart rate and blood pressure in adults with POTS and evaluate the safety and hemodynamics of Region 7544 in comparison to placebo. The project works to link cardiology, autonomic physiology, and clinical pharmacology to develop and make available a novel treatment for POTS. As a project lead of the Calgary site, I am running and coordinating participant testing, handling biospecimens from draw to processing, and sharing data with the New York coordinating site. As the study is still in progress, no analysis or results are currently available to be shared. But aside from all this and beyond a drug study, why does all this matter? Because it points to a path towards the first approved treatment specifically designed for POTS, moving from duct tape to intentional and purposeful treatments. If hypovolemia drives symptoms for so many, then treating the volume problem directly could give people back minutes of standing and moments of their lives. And even if the effect is strongest in just a subset of people, that's still a win for us. Because not only is it a subset containing over 70% of the patient pool, but it also validates phenotyping, matching therapy to physiology in a field that's been hungry for precision and care. So let's return to that living room. Imagine standing up to go out, to parent, and the world doesn't begin to race. Your heart doesn't sprint because you feel steady. Returning that feeling to our patients, that feeling which we take for granted every single day, is why we do this. Standing should never feel like a sprint, so let's make it something our patients can take for granted once again. Thank you, Dr. Satish Raj and the Libin Cardiovascular Institute.